Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsors, Cleveland Clinic Mercy Hospital, Studio Arts and Glass, and a new sponsor today, Genier Appraisals and Liquidations. So today, Brad and I are broadcasting from the administrative offices, and our special guests are Dr. Gregory Boone, General Surgeon for Mercy Surgical Specialists, and Amy Thiel, RN, Breast Cancer Nurse Navigator for Cleveland Clinic Mercy Hospital's Cancer Center. Good morning and welcome to the show.
Thank you.
Thank you. Good morning.
All right. October is National Breast Cancer Awareness Month. And this Breast Cancer Awareness Month, it's time to rise. When it comes to breast cancer, it has never been about the challenges faced rather than the ways we rise to meet the challenge. Breast cancer is the most common cancer among women after skin cancer. The American Cancer Society estimates this year about 252,000 new cases of invasive breast cancer will be diagnosed in women, and about 40,000 will die from this disease. This morning, we're going to talk with Dr. Boone and Amy about breast cancer screening and the options in breast cancer treatment.
So, Dr. Boone, welcome to the show again. Please tell us a little bit about yourself and your role at Cleveland Clinic Mercy Hospital.
Thanks. It's really great to be here today. As Brad mentioned, I'm a general surgeon at Mercy Hospital, but I've spent most of my career focused on breast cancer care. And I guess technically I'm the medical director of our breast center, but what I really am is one part of a really terrific team of people that includes folks like my colleague Amy, one of our nurse navigators, my other surgical colleagues, my radiation oncology colleagues, my radiologist colleagues, my medical oncology colleagues, pathology colleagues, and on and on and on. We have a really terrific team of people that I'm just one part of.
And Amy, to you, welcome to the show this morning. Please tell us a little bit about yourself and your role at the Breast Cancer Nurse Navigator.
Sure. So thank you again for having us. My name is Amy Thiel. I've been a nurse for over 12 years, and all of those years have been spent in the oncology field. The last 3 of those spent here at Mercy as the Breast Cancer Nurse Navigator. Basically, my role as a nurse navigator is to be a support person for the patient. My main role is education. I want to make sure that the patients are comfortable with their treatment options, that they're comfortable with their doctors and the way that everything is going. I educate them on surgery day, what to expect, and I help them get resources if they need those, financial resources, transportation, anything that they would need to help them in their journey.
So, as we know, October is National Breast Cancer Awareness Month. Why is it such an important focus?
Well, it's such a common disease, as Brad mentioned, those numbers are staggering. And so it's just something that, 1 in 8 women in this country, if they live to be 90 years old, will develop breast cancer. So that's a huge impact for our society and for the individual people who are diagnosed with breast cancer. So this is, I don't know that there's anyone around who hasn't known someone who's been impacted by this disease. It's just so common, and the key to curing this disease is early detection. And that's why I dress in my pink scrubs in October, and we try our best to, get the word out that we can cure this disease if we find it early. And it's just everything. So that's why it's so important.
So breast cancer is talked about a lot. What is breast cancer and how common is it?
Well, again, it's very common. 1 in 8 chance of women developing breast cancer in their lifetime. So extremely common. Cancer in general occurs when cells start dividing out of control with respect to their neighbors. And that's, the same in breast cancer. And, as those cells divide, the old cells don't die off. You know, our normal cells all divide and old cells die off and get replaced by new ones. But the problem with cancers is twofold. They're dividing too rapidly and the old ones don't die off. So they start kind of crowding out the normal neighbors, you know, and then eventually become invasive in the case of breast cancers, certainly, and can get into the bloodstream or the lymphatic system and spread to other places. And of course, that's how we get into trouble with cancers.
It seems like there's a constant debate in recent years about breast cancer screening. So when and how should women be screened for breast cancer?
Well, as you said, you know, it's constantly changing as research becomes more available, as we learn more things about cancer and early detection. So the American Cancer Society right now is suggesting that women ages 40 to 44 should have the choice to start their annual breast cancer screenings with mammograms if they wish to do so. And we do recommend that you start mammograms at the age of 40. Over the age of 45, we are saying we are requiring you, we want you to get mammograms every year for screening purposes. All women should be familiar with the known benefits, the limitations, the potential harms linked to breast cancer screening. But I think that the key takeaway here is to know your own body. Know what's normal for you. Practice shared decision-making, discuss the right screening frequencies with your doctors, and just know what's good for you.
You know, there's still a lot of myths and misconceptions about mammograms and radiation exposure. Some women will not have a mammogram because of fear that radiation will give them breast cancer or that it's painful. Can you talk about the realistic risk of radiation exposure and related to mammograms? And I know that the radiation exposure has, has declined. In other words, the amount of radiation, I guess, you need for a test. So where are we at today?
Well, the radiation exposure is really quite small for mammograms. You know, we're all exposed to radiation every day, just walking around and living our normal lives. And I think they estimate, I can't remember, I think I'm right about this number, but the amount of exposure you get from a mammogram is equivalent to about 7 weeks of background radiation just from walking around every day. And so it's really minimal. And there certainly have been studies that show, you know, if women are getting frequent mammograms, even the amount of cancer caused by those mammograms compared to the lives saved by doing those mammograms, you know, it just, the scale tips largely in favor of getting mammograms. So it's a gigantic difference. So the risk is very small. The benefits are very high. So again, you always have to put things in the scale and measure the risks and benefits. And so the risks are tiny. The payoff is huge.
Okay, so once a woman has a mammogram, if she gets that call indicating the need to return for more pictures, should she be worried?
Amy, you're the one who walks these ladies through this process, so I'll let you handle that one.
There's many different reasons why you have to get called back for more pictures. It could mean that you just have some dense breast tissue, maybe a cyst that they're looking at, or maybe even a tumor that even isn't a cancer. We have many benign things that could happen that you would be called back for more pictures. It also may mean that the image just simply wasn't clear enough and they just couldn't see anything. Especially with your very first mammogram, the need for additional pictures might be more increased because there's nothing to compare it to. So a lot of times when you have your very first mammogram, they just need to have a baseline of what they're looking at. So if they see something that looks a little unusual, they may definitely call you back for that as well. But I wouldn't say it's a need for, increased stress or anxiety. But of course it's going to happen. But there's just a very wide range of reasons why you would have to come back for more pictures.
And I would echo that, it's most of the things that we find, even most of the things that we end up biopsying or aspirating turn out to be benign. So the vast majority of things that women are getting called back for are absolutely going to be benign. And should you be worried? No, but you should have healthy concern and follow through if they call you back and say, we need to do some more imaging.
Okay. So the $1 million question, are there steps a woman can take to avoid specific actions to reduce the risk of breast cancer?
So there's really no sure way to prevent breast cancer, but there are things that you can do to lower your risk. I mean, lots of risk factors are beyond our control. Being born female, getting older, we can't control those. Other risk factors, though, can be changed. So I think healthy weight, getting to and staying at a healthy weight, nutrition plays a big part in it. Being physically active, making sure that you're getting some regular physical activity in will reduce your risk for breast cancer. Avoiding and limiting alcohol. Alcohol does increase the risk of breast cancer, so trying to limit your alcohol intake. So there's other risk factors too. If you are at an increased risk of breast cancer, genetic testing is always available for those people that have family histories, that type of thing.
You just touched on genetic testing. You know, what about the genetic predisposition to breast cancer? Should all women be tested for that, or is there a specific recommendation of the population that should consider exploring that option?
Yeah, that's a more complicated question than it used to be. 15 years ago, we knew of 2 genes that were related to breast cancer. Now they're 25 plus. And so it's more complicated. And there are lots of little variations of people who should consider getting tested. But the basics is that, if you have a strong family history, if you have, mothers, sisters, daughters, more than one family member who've had breast cancer, especially if they've had it at an early age, or ovarian cancer, again, especially at an early age, or a man in the family who's had breast cancer. Those things are all things that would make you say, gee, this is a high-risk person who should be considered. There are certain ethnic groups. The Ashkenazi Jewish population from Eastern Europe has a higher incidence of breast cancer genetic abnormalities. So there are certain ethnic groups that should consider it. And then if you're diagnosed with breast cancer, there are certain subtypes of breast cancer. And again, based on your age and things that we recommend genetic testing for. But it's always, I think, important to keep in mind that at this point, we've only been able to identify about 5 to 10% of breast cancers as being caused by a known genetic abnormality. So the vast majority of them are occurring spontaneously and really don't have any high suspicion for a genetic problem.
Wow. Okay, folks, time for a break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Flu vaccine, along with Moderna and Janssen COVID vaccine, are available, as well as boosters. Please stop by any of our stores to get vaccinated. No appointment is necessary.
All right. So how about symptoms? We talked about genetic markers before the commercial break. Are there any symptoms a woman might identify that could indicate the possibility of breast cancer?
I think the short answer here is no. Know your body well. I'll go back to that. Just making sure that you know your own body. Change in the breast texture, the skin, retraction of the nipple, any nipple discharge. Report those to your doctor for workup immediately. However, it's important to know that breast cancer in its earliest stages has no discernible symptoms. So deciding on appropriate screening strategy, again, with your physician, and taking into account your personal factors in that is very, very important. But again, cannot stress enough, early detection, early screening.
Okay, so how about this? After an abnormal mammogram, what happens next?
Well, those are those callbacks that Amy was talking about earlier. So if you have an abnormal mammogram, it's not uncommon to need to come back to get some extra pictures to better define what's going on, because sometimes with those extra pictures, we can clarify and find out, hey, this isn't something we need to worry about, and then send folks on their way. Of course, on the other hand, sometimes we do find things that are concerning, and biopsies then might be recommended, which has become considerably easier. You know, I'm an older guy. I've been doing this for 31 years, and the change in how we do that has dramatically changed for me in those years. Everyone who needed a biopsy when I started went to the operating room and had a regular old-fashioned incision and had something removed. Now we can do small needle biopsies that are very quick, simple, easy, low risk, and don't really take a whole lot away from the patients. You know, they get back to doing their normal activities and normal work within a 24-hour period after they have these. So the way we approach things that need biopsied has really revolutionized in my own personal career, and has become much simpler and much less what we call morbid, meaning causes much less problems for patients.
Probably answered half of this question, but doctor, but once cancer is diagnosed, are all women going to have surgery?
Well, you know, most certainly are. There are some few exceptions to that rule, but you know, the mainstay of treatment for breast cancer still remains surgery. You know, my role is twofold. Number one is to treat the disease locally in the breast. So you do always want to treat that disease in the breast itself. And then the second part of my job is to gather some of the information we need to help guide other treatments that might be needed. And that's, again, usually by testing and sampling lymph glands, which is the earliest place if breast tumors were going to spread. The earliest place they would do that would be to the lymph glands underneath the arm on the side of the tumor. I should tell you, most women, when they're diagnosed, if they're diagnosed early, don't have spread to their lymph glands. So it's only 20 to 25% that do. And once again, that's become a much better process in my career. When I started, every woman who had breast cancer had all of the lymph glands under their arm removed, which was a good thing if they had cancer in those lymph glands. But 75 to 80% of women did not have cancer, and there are risks to doing that. Now we sample the lymph glands. We sample, you know, a couple of lymph glands, which we call the sentinel lymph glands, and base what we do with the rest of the lymph glands on what we find in those couple of lymph glands. And again, that's part of my job as the surgeon to do that, and that helps guide other treatment recommendations.
So again, we may have covered some of this question, but what are the surgical options?
Well, most women, and again, this depends on the size of the tumor and the size of the breast. Most women have two options for treating the disease locally in the breast. And of course, the most dramatic of these options, and the one that I think most ladies think about first and worry about first, is mastectomy, or removing the entire breast. You know, and obviously if you have a lump in the breast that's a cancerous lump, if you are to remove the entire breast, that would likely help control the disease in the chest. And it's certainly an option that some women desire, and it's a reasonable option if that's what you want to do. You can do that, by the way, with reconstruction, and by federal law, your insurance company must pay for that. So it's considered part of the treatment, not some kind of cosmetic procedure. It's part of restoring normal. But the other option for a lot of women these days is to do what's commonly referred to as lumpectomy, meaning removing the cancerous tumor with some normal tissue around the tumor. And we know that if you do that and combine that with radiation treatment, for most cancers, that is equivalent to doing mastectomy. So the long-term cure rates are equal.
So since breast cancer is so common, everyone, it seems like everybody knows somebody who has had it or has it. Um, why are the treatments so different? Why do some people have chemo, but others don't? Radiation, others don't. Doesn't everyone with cancer need chemo?
Yeah, it's because cancer is different for different kinds of breast cancer, and there are varieties. So one of the things that we look at is, are these tumors hormone receptive or hormone responsive, I guess is the better word. And we can identify these things we call hormone receptors. If those are present, it tells us that if we can block the areas of those cells that respond to the estrogen hormones predominantly, then we can treat those with pills and simple things like that. And some women that works for, and some women have estrogen receptors that are not present, and so those won't work for them. And it's become, again, a little more complicated how we decide who needs chemotherapy and who doesn't, but certainly to the great benefit of the patients. And again, if you go back in history to when I was a kid starting out, any woman who had cancer in their lymph glands got chemotherapy. If you didn't have cancer in your lymph glands, you didn't get chemotherapy, which was the wrong thing, because there was a group of ladies with normal lymph glands we undertreated. Now, today, we can actually study the genetic makeup, not of the patient, but of the tumor, and predict who will and who will not benefit from things like chemotherapy. Again, a really revolutionary change in breast cancer care since I started my career 30 years ago. It saved a lot of women from unnecessarily having chemotherapy. So we can really tailor the treatment to the patient's individual cancer by studying these receptors, by doing sometimes this genetic testing, which is commonly called oncotype testing on their tumor. So we tailor the treatment to what the patient specifically has. It's not a one size fits all.
Hey, time for the news. Thanks for listening to us this morning on Health Matters with the Medicine Center Pharmacy. This morning on Health Matters, we're talking with Dr. Gregory Boone and cancer nurse navigator Amy Thiel. We've got a lot more to cover this morning, so let's get back to the show.
Okay, before the break, we talked a little bit about cancer chemotherapy. What about radiation? Do all women need radiation treatment after breast cancer?
Yeah, not all. Radiation is commonly recommended if ladies choose to have lumpectomy or breast preserving operations to treat the remaining breast. So probably the majority of women that have breast preserving operations, again, lumpectomy, will need radiation. There are occasions with mastectomy that you also need radiation, but that's probably the exception, not the rule. So no, not everyone needs radiation therapy.
Okay, so let's talk about some medications. Many women must take pills after breast cancer for hormone blockade. What are the benefits of these types of medications?
Yeah, that's a great question as well. So again, as I had mentioned earlier, one of the things we look at on cancer cells, kind of under the microscope, is whether the tumor cells have these things called hormone receptors. And the way I try to explain it to patients is it's kind of like the ignition in your car. If your cancer cell has these hormone receptors, there's a place where the key, the estrogen, can get in and turn that motor on, which actually sounds like a bad thing, but the truth is having positive estrogen receptors is a good thing. And the two reasons why. Number one is that if you just compare women whose tumors are estrogen receptor positive to estrogen receptor negative, and everything else is the same, if you look at how they do 5, 10, 20 years down the road, women with positive estrogen receptors do better. So biologically, it's a marker that it's a less aggressive tumor. And then the second reason is these hormone blocking drugs, which are pills, fairly simple to take with low risk profiles. Those are like sticking glue in the ignition. Now the estrogen hormones can't get in and turn that motor on anymore. And it doesn't work if you don't have those receptors. So that's why it's a good thing to have positive hormone receptors. The other big thing besides treating the cancer that the patient has today is that these drugs have also been found to reduce future breast cancer risk, and not just in the side with the cancer, but on both sides. And that risk reduction is huge. It's greater than 50% risk reduction. And that's a big, big, big deal. So these drugs are, again, revolutionary and really have a huge impact on ladies' lives.
So how effective are these treatments? You just
Yeah, they're very effective. And again, as I pointed out, not just in treating the cancer and reducing the risk that there would be a recurrence down the road, in some distant place like lungs, liver, bones, things like that. But also, again, and for me, I can't emphasize this strongly enough, those hormone blocking drugs help prevent new cancers from forming in the future. And, again, the impact of that just can't be, overemphasized. It's a big, big, big deal. So they're
So
quite effective.
thinking about dietary restrictions and organic foods and supplements and even cosmetics, how concerned should women be about getting estrogen exposure through foods or products that they interact with on a daily basis?
So there really is a clear connection between being overweight, obese, not being physically active, and your risk of breast cancer. Your risk of breast cancer is higher when you are obese. There are many studies that have been done, but to date, none have really found to actually concretely pinpoint anything in the diet that specifically affects breast cancer risk. So because diets high in fat can cause obesity, which is linked to breast cancer risk, we definitely discourage high fat diets. There's really no study that's proven that any type of vitamin regimen will reduce the risk of breast cancer also. However, again, a healthy diet low in red meat, processed meat, fat, and high in fruits and vegetables has many other health benefits, including lowering the risk of cancers, diabetes, heart disease. We definitely here at Cleveland Clinic Mercy have a lot of weight management programs. We have outpatient dietitians that can meet with our cancer patients, and that's something that we as nurse navigators can get the patient hooked up with. So that's very important to do as well.
And just, I would add one thing to that, because you mentioned supplements. I would just encourage patients to let their doctors know what supplements they're taking, because these can have impacts on your care and your treatment down the road. So it's really important that they kind of treat those like they're other medications and just say, hey, I'm taking this over-the-counter supplement, so that we can just be aware of it and make sure that there aren't going to be some kind of interactions that might harm them.
And I think you got to watch too, because sometimes cosmetics and like hummus, I mean, there can be estrogens in those. So just read your labels and be aware of, what you're exposing yourself to.
Right.
So many women who've had treatment for breast cancer have concerns about body image after treatment. What resources are available to help them assist with these worries?
And again, anymore, technology and science and products and things that we have available to ladies and even men with breast cancer has really increased. We've really gotten a lot better at helping with body image after surgery, especially. Cosmetic reconstruction is always an option after a mastectomy. They even have fantastic tattoo artists that do 3D nipple tattoos, which are really amazing. Here, again, at Cleveland Clinic, we do have the Mercy Boutique, which has lots of things available. We have a wig program. We have wigs available if you're going through chemotherapy. We have prosthetics. We have bras. The bras have come a long way, too. They actually are prettier now. They're not Victoria's Secret, but they're definitely prettier than they used to be. We even have partial prosthetics. If you found that, you did have breast sparing surgery or a lumpectomy instead of a full mastectomy, and you're finding that maybe you don't like the way you look in the mirror, we have ways that we can help with that as well, with partial prosthetics. So the Mercy Boutique is open here Monday through Friday. It's 10 a.m. to 4 p.m. You can feel free to call and make an appointment if you want, or you can just come in. The phone number there is 330-456-9960. That's how you can make an appointment.
Very good. There always seems to be a lot about breast cancer in the media, and especially during October. Are there any promising new developments in breast cancer treatment or therapy that's being researched now that you're excited about?
Wow. Yeah, I mean, there are just so many areas where there's exciting research and hope coming down the road. Some of the more aggressive cancers like triple negative cancers, there are a number of new drugs that are being studied right now and being tested that we have great hope will give us better outcomes. The receptor we hadn't talked about that we looked at is a thing called a HER2 receptor. And again, 30 years ago when I started, we had no treatments for these things. And now there are numerous drugs that can attack that receptor and help to treat those cancers, which we formerly, kind of looked at as a little more aggressive and a little worse outcome. So we're doing better with those. We're looking at all kinds of things. We're looking at trying to minimize our surgeries. Can we do less surgery in those lymph nodes underneath the arm? Is radiation better than surgery for that? And so there's some exciting research coming with that. We're also looking at, does every woman who has a lumpectomy really need radiation? And right now I know we're enrolling women in a study at our institution looking at, can we de-escalate radiation therapy for women who have tiny favorable tumors? Maybe we don't need to do as aggressive treatments. So all of those things I think are exciting things on the horizon that can really, again, make a real difference for ladies' long-term outcome and getting through their care.
We're close to another break, but I wanted to ask, I've been a pharmacist for a long time, and oral contraceptives came into play, I think, in the early 60s. And what is has been the effect of, some of these oral contraceptives in the early days were really powerful. I can remember a 10 milligram Enovid and some other products out there. What has been the effect on breast cancer with some of these early high dose products?
Yeah, well, I don't think there's any question that, the combination hormonal treatments with estrogens and progesterones, progestins have been shown to increase breast cancer risk. And so, we certainly would prefer people not use those things long term. And of course, they've changed a lot. As you mentioned, they're not really those doses that they used to be. And then, of course, the other concern is long-term hormone replacement therapy. So even estrogens by themselves, taken for long periods of time, increase the risk. And I think these days, that's being utilized less and less. We used to think there were benefits to those estrogens that turned out not to be true. We used to think that heart disease was decreased by taking estrogens. It turned out not to be true. And we have ways of managing the symptoms and the problems associated with those lack of hormones that are safer and better than using hormone replacement therapy these days.
Okay, our final break is here. You're listening to Health Matters with the Medicine Center Pharmacy. Hey, welcome back to Health Matters. I'm your pharmacist, Paul White. This is our final segment of the show.
All right, we are back. We are nearing the end of our program, but we want to make sure that we have a nice closing message from our guest today. So I wondered if you had like the biggest takeaway from today's message that you wanted to share with the listeners, and try to make sure that we highlight what's most important in the realm of breast cancer care for all women?
Well, I mean, I would say get your mammogram. It's the key to early detection. It's the key to cure. I can tell you without question, mammograms save lives. So that would be my take-home message. Please don't skip your mammogram. You know, in these days with the COVID pandemic, women have not been going in to get their mammograms because of concerns of exposure in the hospital. And we had those concerns. And I think we made some mistakes in not pushing women to go ahead and get their screenings. But we realized that that's an error and that we really need to have women get their mammograms. So please, for goodness sakes, if you're due or overdue, please go get your mammogram.
I would be remiss if I didn't also say early detection saves lives. So get your mammograms definitely. But one thing in my practice that I have learned from talking to women, actually talking to any patient that has a cancer diagnosis, not just breast cancer, is they always ask me the same question: what did I do wrong? And I want to make sure to let listeners know that cancer is not your fault. Yes, there are ways that you can lower your risk of getting cancer. We've already talked about those. Don't smoke, don't drink a lot of alcohol, maintain a healthy weight, eat a good diet. But cancer is not your fault. You did not do anything wrong to get this disease. It can happen to anybody. You could be the healthiest person ever, and you could still get cancer. So I think, again, that's one of the main things that I try to let my patients know, is that they did nothing wrong.
Amy, you mentioned some contact phone numbers earlier in the program. I think it'd be important if you shared with the listeners not only those numbers, but also how they can reach out to Cleveland Clinic Mercy Hospital to get some guidance. And I'm probably thinking you've got some support groups you might want to highlight too.
Well, unfortunately, because of COVID, we do have a fantastic breast cancer support group, but it has not been able to meet in person because, again, of the pandemic. But we do have a Facebook group that some of the ladies have created. It's called Women of Courage and Strength. It's on Facebook, so you can look it up and join that. Again, it's a group of wonderful ladies that started here in the in-person support group and have kind of continued it out on Facebook. We are going to try to hope to get some things online. It's hard sometimes to get Zoom calls, to do Zoom calls and get everybody together. But if you are, looking to get a hold of a nurse navigator, either me, the breast cancer nurse navigator, or any of the other navigators, you can go ahead and call in to our main line, which is 330, hold on, I'm getting it right here, 489-1278 is our line that you can call to get a hold of somebody in the cancer center, one of our nurse navigators. Again, the boutique is 330-456-9960. I'm available all the time.
Very good. So we appreciate you joining us today and sharing your message. Is there anything on any other resources for patients that you'd like to touch on? Doctor, you mentioned a book to me earlier. Are you interested in sharing that with the listeners?
Sure. Yeah, we were talking before the broadcast about a really interesting book about the challenges of caring for cancer, not specifically breast cancer, written by a medical oncologist, but really written for non-medical people, that reads like an adventure novel called The Emperor of All Maladies. So it's just a very interesting look at how cancer has kind of come into our lives and how we approach it and what the future looks like. So that's a very interesting book. And there are lots of great organizations out there that you can turn to for help, you know, the American Cancer Society, the Susan Komen Foundation. Those organizations have really reliable and good information. You know, I'm a big fan of the internet, but you got to be careful. So go to reliable sources like those. The Live Strong Foundation is a great cancer resource for all kinds of cancers, not just
Okay.
breast cancer, which is.
Hate to cut you short, Doctor. We are absolutely out of time.
Okay. Hey,
Okay.
thank you very much for having us.
And you bet. Thank you, our guest, Dr. Gregory Boone, General Surgeon from Mercy Surgical Specialist, Amy Thiel, RN, Breast Cancer Nurse Navigator for Cleveland Clinic Mercy Hospital Cancer Center. We'd like to remind you, listeners, that if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsors again, Cleveland Clinic Mercy Hospital, Studio Arts and Glass, January Appraisals and Liquidations, and of course, our technical producer, JD DeAngelis. As always, we thank our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week. See you again right here next Friday on News Talk 1480 WHBC.